All right, so why don't we go ahead and get started. Good afternoon, everyone, and welcome to today's webinar. Today we have Dr. Rashmi Kathari and Dr. Marc-Olivier Deguy here to talk about does low SMN in spinal muscular atrophy lead to a unique metabolic state? We're grateful to our speakers today to talk about this topic. As I'll mention, they recently did publish a review paper, Metabolic Dysfunction in SMA, earlier this year. And we've received a few questions through a research hotline about the article. So we're thankful that they'll be able to expand on the article and talk more today. Dr. Kathari is the Deputy Scientific Director and Senior Scientist at the Ottawa Hospital Research Institute. His current research focuses on understanding spinal muscular atrophy, pathogenesis, and identifying novel therapeutics for this condition. Dr. Deguy is currently a pediatric resident physician at CHIO and has been involved with the SMA community through research for the last 8 years. He obtained his MD PhD combined degree at the University of Ottawa under the supervision of Dr. Kathari. Really thankful to have you both here today. I'll go ahead and stop sharing my screen. As I do that, I should mention that this webinar series is in recognition of SMA Awareness Month, SMA Action Month, as some have put it. And so we're really excited to hear about this work. Over to you.
Okay, well, thank you, Homera, for that wonderful introduction. And I'm really excited to present today let's say some thoughts about novel areas in spinal muscular atrophy. This is really, something that Marc-Olivier really spearheaded in terms of research, in terms of investigating why we're thinking about metabolic dysfunction in spinal muscular atrophy. And it came to a point, I think, largely due to his research, that we decided that it deserved a review or an overview publication, which came out this spring, and it was nice to get it out there as a way of debate, as a way of discussion, and sort of for not only for researchers but for clinicians and families to kind of think about the involvement of metabolic dysfunction in spinal muscular atrophy. So I'm going to start off by presenting the introductory parts of the talk, and Marc-Olivier will follow with sort of more right to the core of the discussion on why his research led to our current thinking of metabolic dysfunction in spinal muscular atrophy. So if Marc-Olivier, if you could share the screen. Did we lose him?
I think so. Why don't we give him a minute to
Okay, let him rejoin, and just I'll keep the ball rolling. So it's it is SMA Awareness Month, which always it's exciting that we can highlight spinal muscular atrophy to Canadians, and in fact throughout the world. I think it's the SMA Awareness Month, but it's something that goes on for a number of it doesn't just really peak in the month of August. The work goes on throughout the year. Now, unfortunately for Marc-Olivier, I think he just got somehow pushed out. So he's going to try and log back in, and I'm going to try and start the presentation. So that way we don't lose any time. I'm just going to grab just make sure that I have it, and then I'm going to share the screen. Okay. Marco, are you back? Here we go. Thanks, Marco. So if you could go to the first slide, we'll get the ball rolling. Just before we start up, we wanted to make sure that we had our disclosures and also the acknowledgement. As always, work in the research and clinical community doesn't occur in isolation. We've had numerous collaborators within our lab, but also outside our lab, national, international collaborators. They're all listed here. And if we missed some, please forgive us. There's always a possibility that we missed a few. We also had a lot of support in terms of funding. I wanted to highlight the fact that Muscular Dystrophy Canada has been a strong supporter for our research, as has other organizations. Acknowledgements to those as well. Next slide. So I'm sure most of you are quite familiar with some of the background on spinal muscular atrophy, but I thought I would at least put it here and kind of go through it systematically. Now, spinal muscular atrophy is fairly complex disorder in terms of its presentation. It is, generally speaking, a severe and progressive neuromuscular disease, which means that there is a period when things do look normal, but soon after birth, there is a rapid onset and progression of the disease that affects many aspects of an individual's life. It is characterized by progressive muscle denervation, what this means is that motor neurons which control our muscles undergo damage and we start to lose them. This loss of connection of the motor neuron to the muscle then leads to inactivity of the muscle, and therefore the muscles start to shrink, and this is called atrophy. And that's why the disorder is called spinal muscular atrophy. This leads to an overall weakness and then loss of motor function and ambulation. Now, remind you, it's a genetic disorder in young children, and its severity spectrum is determined by copy number of the second gene. I'll explain that to you in a minute. But some of the complications that can arise in spinal muscular atrophy, which actually do impact survival, include the scoliosis or curvature of the spine. There is a repeated episodes of pneumonia. This leads to the respiratory distress. And there is certainly difficulties with sleep and nutrition. And so there is a great need for support at the respiratory, nutritional, orthopedic levels. And collectively, this can impact the survival of the individual. Next slide, please. This is a little complex, perhaps, but don't worry about it. I just wanted to highlight the fact that the gene responsible for spinal muscular atrophy is called survival motor neuron, or SMN1 in the human. And one of the things that makes it unique in humans is that we have two genes that are highly related. And that's why you have SMN1 and SMN2. SMN2 is nearly identical to SMN1. There are a few differences, and the key difference is one nucleotide or one letter in a sentence that is misspelled, and this misspelling of the word in the sentence leads to a compromised gene, so that it only produces 10% of the time normal protein. So what happens in SMA is that we have mutations or deletions that impact the really good gene, SMN1, which is no longer functional. And so we're now dependent on the second gene or the copy gene called SMN2. And as I mentioned, because of this one spelling mistake, it is only able to make good protein 10% of the time. And so that's why we have spinal muscular atrophy. And the more copies of SMN2 we have in our body, some of us have 2 copies, some have 4 copies. So the more copies we have, the milder the symptoms of SMA, to the point where if you have 8 copies of SMN2, you could be virtually unaffected by the disease. So the more copies of SMN2, the better the outlook. In the next slide, I just wanted to kind of reinforce this notion about a sentence and a spelling mistake. So what we have, is the importance of that comma. In a normal situation, if this is the sentence, let's eat, grandma. But if you have one spelling mistake or one mutation that removes that comma, it translates to let's eat, grandma, and that's not a good thing. So just to kind of highlight that one single spelling mistake can lead to quite a different interpretation of the outcome from normal, which is on the left side, where you have normal full-length SMN, or on the right side, where you have one spelling mistake, which leads to abnormal protein or delta 7 SMN as it's known, which is not a good thing for spinal muscular atrophy. So I hope that explains to you why we have the situation of spinal muscular atrophy. Next slide, please. Now, the gene itself that's responsible for spinal muscular atrophy was identified well over 25 years ago, and really led to a lot of work that we refer to as preclinical, meaning before the clinic. And a lot of the work was focused on developing mouse models of spinal muscular atrophy. And this was in the era of, trying to understand what the gene and the protein does, developing model systems so that we could study the pathogenesis of the disease. And really, it was the work of Umar Monani when he was with Arthur Burgess that led to the creation of the first mouse model of SMA. And this is over 20 years ago, and is depicted on the slide, a normal control mouse on the left, and the affected pup on the right. You can see the obvious difference in size, but there were also neurological abnormalities within the pup that reflected very similar situation in spinal muscular atrophy. So the next slide, please. Now, a lot of work has gone into what we have today. And the exciting thing is that we have not one, not two, but 3 drugs now in the clinic that have been approved, at least at the FDA. And within Canada, we have approval for Spinraza, and I believe for the Zolgensma, which is a gene therapy. And all of these drugs really came through studies on mouse models of SMA. I really wanted to emphasize that fact that, we have a lot to thank the mouse models for giving us these important drugs and treatments that are presently available in our clinic. So that's the exciting piece of news. Next slide, please. So we do have treatments, and when the first treatments were hitting the clinic, often would be asked the question, well, do we need to continue to do research now on spinal muscular atrophy? And my answer, of course, is yes, because these are treatments, they're not cures. They do help patients with SMA, but they certainly don't cure the patients. They still, there are non-responders to some of the treatments. Some of these treatments, although they improve the natural history of the spinal muscular atrophy, the individuals still have aspects of the neurological deficit. And what we're concerned about is that the longer the SMA patients live, there is a possibility that we will now be exposing underlying comorbidities in non-neuronal tissues. So next slide, please. So as I mentioned earlier, spinal muscular atrophy is really classically defined as a motor neuron disease with muscle atrophy, and that's shown schematically on this slide. On the left is a normal motor neuron innervating a skeletal muscle fiber. In spinal muscular atrophy, you have neuronal dysfunction that leads to the denervation, the separation of the nerve from the muscle, and then the muscle starts to shrink, and that's the atrophy. Next slide, please. But what's important to understand is that the proteins, SMN or survival motor neuron, is expressed throughout the body. It's not just expressed in the motor neurons or in the muscle. It's expressed in pretty much every tissue or every organ that we've examined. It's expressed certainly in the brain, but in the retina, in the spinal cord, in the testes, in the kidney, in the lung, and for the interest of this particular talk, in the liver as well. Next slide, please. And the other interesting piece of data or news came in a series of studies from the laboratory of Adrian Krainer. And Adrian Krainer's lab is the one that's really being celebrated for the discovery of nusinersen or Spinraza, and which is an antisense oligonucleotide therapy that's currently in the clinic. Well, during their preclinical studies, what they identified was that there is a difference in the result depending on how you deliver this antisense oligonucleotide therapy. If you were to introduce it by intracerebroventricular injection, which is very similar to intrathecal injections, which is the current mode of delivery of this antisense oligo in humans, then in the preclinical model, what you do see is a remarkable increase in the expression or the level of the SMN protein. But this is seen in the CNS alone, so in the central nervous system. And if you look at how the impact on survival in this model, that was a modest twofold increase in median survival. In contrast, if you were to introduce this therapy by subcutaneous injection, so it's very much a systemic delivery in the same preclinical model, now you saw a moderate increase of the protein in several tissues and organs, the heart, the CNS, the muscles, and a strong increase of SMN in the liver. And the impact of this in terms of survival was much, much more dramatic, 25-fold increase in median survival. So this, again, highlighted the fact that peripheral therapy is better than central, and points to the fact that the importance of restoring SMN in tissues other than the central nervous system is critical to achieve the best treatment that we can get. So in the next slide, I think Mark Olivier will be taking over from here.
Right. We'll try this again. If it stops, then we'll be back. So as Dr. Kathari really well explained, there's multiple reasons why we should care about peripheral tissues. First, it can help with therapeutic formulation and knowing whether there's any combination of therapies that we can use that may be helpful. We can also have improved surveillance of what we could expect might happen, especially when we're going to have, a lot more of aging SMA patients that are going to have been on therapy with going forward. And also something that Dr. Kathari already alluded to is that some deficiencies, as we have the sustained, perhaps just a little bit lower SMN level, may just be enough to enhance some of the susceptibilities that the average population is already at risk for, such as cardiovascular disease, stroke, diabetes, other things that the average population already with age may be seeing. So over the course of the time that I've been studying SMA, there's been a lot of research that has been done to find out what's going on with the peripheral tissues and what are their contribution. And initially when I started, there was not nearly as much. This actually mostly happened in about the span of 6 years, I'd say between 2012 to 2018, actually maybe 2010 and 2016. And really the numbers of papers that have been talking about SMA and systemic findings have been increasing really significantly over the course of the last few years. And as you can see, really the bulk of the work has been done in the past 10 years. And one of the situation that Dr. Kathari and I were really interested into was old findings that had never been actually looked at again and had kind of been left aside for well over 20 years. And it started with a paper that was done in 1986 talking about Darkcarboxylic aciduria, thinking that there might be something wrong with fatty acid oxidation, which is one of the ways that we use energy in our body. And again, there was a few papers in the 1990s, and all of a sudden we had a very, very long hiatus of nothing at all. Yet the consensus statements for spinal muscular atrophy care was always discussing that we should have more research on these topics. We should be careful as to how we set out our nutritional guideline, if any. And so really that was interesting to us that really nothing had been done over the past 30 years, and that and we wonder multiple things. First, we wonder, whether or not that had been real. Was other researchers also looking into this and really not finding anything? Why has it not been studied if there seemed to have been something abnormal, yet nothing after? And then lastly, does SMN play a role in fat metabolism if truly there was something there? And so we first started by looking at our SMA models, one of the ones that we had created in Dr. Kathari's lab by Dr. Bowerman, one of the past PhD student of Dr. Kathari. And what we identified initially was that, in fact, those mice that have less SMN in their body actually developed what seems to be non-alcoholic fatty liver disease. So as you can see, the liver is quite fat. All those inclusions, all the white is little fatty inclusions. If you look closer, they're actually all within the cells, which is usually described as microvesicular. And when you do reintroduce SMN through a viral vector, similar to Zolgensma, you get essentially complete phenotypic rescue of this phenotype. When we look at multiple markers of cholesterol in the blood of these mice, we also noticed that they had higher total cholesterol, and as well as other markers of elevated cholesterol, which you can see here, bad cholesterol. This is your good cholesterol, and instead was on the low side. So the next question we had was, of course, is this also present in SMA patients? And this is data that already has been published, and I think has been discussed already in some of the meetings with MDC. But just to recapitulate some of this, when we looked at a cohort of SMA patients, most being between about 2 years to 10 years of age, untreated patients, we find that many of them actually had what we would call abnormal cholesterol levels. And here we looked at 5 measurements, and you can see that as much as 40% of them had at least one, 20% had at least 2, and then for 3 measures of abnormal cholesterols, there was about 15% of them. If we compare that to already published values for pediatric population, we see that this is almost doubling the frequencies, especially if you looked at more than 2 and more than 3, for which there was actually absolutely no data available. Then we looked at whether or not there was fatty liver disease and some of the necropsies that Dr. Michaud, one of the pathologists, had seen in the past. And what he identified was that there was actually about 37% of the livers he looked at that had fatty inclusions in them. When you compare that to published statistics for children of that age, it's about 0.7%. So quite a drastic increase in comparison to what you might see in the average population. One of the other things we noticed in our mice was that they were really having low blood sugars. And we weren't not quite sure about the reasoning for this, but we again wanted to see whether our SMA patient cohort also had abnormal glucose. So we started with an HbA1c, which is essentially an average measure of your last 3 months of the blood sugars. And this is usually used to monitor diabetes. So generally when you have a higher HbA1c, it means that you have a little bit of a poorer control. In the case of our SMA patients, most of them actually had a lower HbA1c, one that is below 5%. That's not generally something that most clinicians fuss about, but when you look a little bit at the data with low HbA1c in published data sets, a lot of populations that have been studied found that when it's below 5%, generally it's associated with poorer outcome. It's associated with liver disease, which strangely is also what we found, and disability, and in other populations that are not neuromuscular disease. So then we were interested in knowing more about what's actually going on in our mouse models, and whether or not, on which spectrum of non-alcoholic fatty liver disease did we fall. Non-alcoholic fatty liver disease actually has a wide phenotypic spectrum. It can be described as just simple steatosis, meaning that there's only fat that is accumulating. Steatopatitis, where you have also inflammation, and you may have some liver cells that are starting to die. And finally, the end stage of that spectrum being where your liver becomes fibrotic and starts having lower function. And so if we looked at some level of damage of the liver, so ALT, AST are both common measure that we use in clinical settings to identify whether there's any damage to the liver, we find that they were both elevated in our mouse. When we looked whether or not the cells were dying more commonly in the liver of the SMA mice, we found that certainly there was a lot more immunofluorescence of caspase-3, which is a marker of cell death. And finally, when we looked at different pathways of fibrosis players, we find that a lot of them, as you can see on this side, are actually upregulated, telling us that there might be already fibrosis happening, yet though we hadn't seen any fibrotic fibers on the livers that we had studied. Finally, one of the things that I had mentioned earlier was that at some point with fibrosis, you also may get some dysfunction of the liver. And so those are two commonly used clinical readout that we use for hepatic function. We find that the total protein was actually lower, so the liver was producing less protein, seemingly was also producing less albumin. And finally, IGF-1 has always been of interest in the preclinical world for SMA, so we were interested to see what IGF-1 was in our mice, because it is produced by the liver. And what we see is actually that the IGF-1 level is becoming more and more decreased to the point that there's almost no production at the end stage of the mice. So then we went back to the books and tried to identify what are the possible etiologies that may lead to this non-alcoholic fatty liver disease phenotype in the mice that have less SMN levels. So the way it works is really a little bit of an imbalance between what you put in and what you put out. So the few things that you may consider going in the liver includes what we eat, includes some of the lipids that come from your fatty stores. So, and actually most of the lipids that go in the liver comes from your fatty stores, and just a little bit comes from your diet. The other things that may actually change this is whether or not your fatty stores are healthy or not. And because we don't realize that, but all our fatty stores are actually living cells. And so depending on how healthy they are, they may also contribute to releasing more lipids in the circulation. Finally, if we are sensitive to insulin, so as in the case, for example, of diabetes, that would be exacerbating this phenotype. On the other side, what may be protective, or if dysfunctional, making things worse, is the mitochondria. So the mitochondria can burn all those lipids. And lastly, the lipoprotein, so the cholesterol we put in the blood, most of it comes from the liver, and is excreted by the liver. And so if it packages and put it in the circulation, then that helps removing some of the fatty inclusions in the liver. What we first were curious about was whether or not, if we take another model that has muscle denervation, such as a model of ALS, do we see again a fatty liver? We found that in ALS mouse models, there was no non-alcoholic fatty liver disease phenotype happening. So we removed the denervation piece, and so we could finally focus on these 5 aspects. When we start with the output, so we were curious because mitochondria have been explored in SMA, were thought at, and are still thought to have some issues to some extent. So we were curious to see how the liver mitochondria were functioning. We had found on the screen that mitochondrial protein were highly misregulated, and so were lipid metabolism proteins. When we looked at their function, we actually found that they were functioning much better. And that kind of makes sense now that we looked at it in hindsight, because those mitochondria are in overdrive to remove all the fatty inclusions that are in the liver. And so when they are in overdrive, though, that actually brings about other type of oxidation. And we found that there was also microsomal oxidation, so another type of pathway that was trying to also remove all the fatty inclusions. And this actually leads to the carboxylic acids, which, if you remember from one of the first slides, is one of the things that was found in infant with SMA. So that was very interesting to us that we could actually corroborate those results from a preclinical standpoint. The next thing we looked at was whether or not the SMA mice had good insulin sensitivity. So we did that by just looking, if we give them insulin, is the downstream protein reacting the same way? So if we looked here at a normal mice, responded very well to insulin, so increased the ratio up to 15 times. And then when we looked at our SMA mice, they actually were not able to mount the same reaction, telling us that the insulin sensitivity was probably already affected in these mice. The next thing we looked at was whether or not there was increased fatty substrate that went in the circulation from any of these sources, but we focus mostly on the adipose tissue. And there's an easy one to do with just to look at non-esterified fatty acid, which are a product from your adipose tissue. And we found that over time, these were actually increasing quite a bit. So knowing that the fatty stores of these mice were actually putting out a lot of substrate in the circulation, which was picked up by the liver. And we tried to identify why that was. And glucagon is actually one of the hormone that is used during fasting state. It help modulate and making sure that you have enough energy when you're not eating. And so that's a great hormone that helps you keep your energy levels steady. But when you don't have any more sugar, what it does, it goes and gets all of that directly in your fatty tissues. So at that point, we think that glucagon is actually the main driver of this non-esterified fatty acid overload that all goes into the liver. So with all of this, we had new questions, and a lot of questions that so far hadn't been really answered for us because it was really a topic that hadn't been touched in many years. So, and of course, there has been a lot that has been done since 2016, a lot of new findings, but the main thing is that there's really not a lot of research that is aimed at translating the results that we find in preclinical models. As you can see here, lots of results, but not so much on the human side, which is hard and understandably for multiple reasons, which we'll go into a little bit later. So the first question we had was, how do mice and human compare when we review all of the literature? Can we find anything in our results that match what is already published? And so when we do compare both the mouse models and the human patients, what we find is that both of them have abnormal cholesterol levels. Both of them have increased fatty liver. They seem to both have insulin resistance in some cases. And both population also have slow GI transit, constipation, and likely Darkcarboxylic acid production in certain states. Some of the things that didn't quite match was the fact that there's low IGF-1 in the mice, but that was never found in humans. There's high glucagon in the mice, that was never found in humans. And so there's still some small discrepancies that we'll have to find out. And that opens the door for more research for sure. Some of the big difference, and why are those so different? Well, there's multiple reasons really. When we think about a mouse model, it is a much simpler organism. And while we think about human patients, very complex. And if we go further than this, in mouse models, we have a very narrow spectrum of disease. All our mice show exactly the same symptoms at the same time, and we know exactly the progression of how this is going to go. But for human patients, everyone's different. Everyone has a different environment. Everyone has a different genetic code, which brings me to the next thing is all our mice are genetically the same. This is very different to what we see in human patients. Everyone is different. Everyone has a different genetic code, even though it's quite similar. It is also very different with different polymorphism, which are different little base pair difference in your genetic code. The environment is widely different. All our mice are in the same place. They eat the same thing. They all do the same stuff. But that's not the same thing for human patients. So we do expect that there's going to be differences. And then lastly, mouse models, are accessible, and human patients, not everything is something that we can look at, and that's important to think about. Is that first, do no harm, right? So that's really, really important to think about that when thinking about doing some research. So going further, we had other questions, and the other questions had to do with how does what we found in SMA compare to other neuromuscular disorders? Because one of the common question was, well, how do you know that this is just not because of muscle denervation, because they have less muscle mass? And so we thought about this question long and hard. We looked at all the literature we could. We took 3 diseases that we thought was mostly giving similar motor phenotype in terms of denervation. So we took spinal and bulbar muscular atrophy, ALS, as well as spinal cord injury. This is a very busy slide, so I don't expect you to necessarily retain anything, but this is a Venn diagram of the 4 diseases. And what we found was that essentially when you look at the 4 diseases, the things that come commonly are this difference in cholesterol, though not always in the same direction. So in SMA, we know that it was increased. In SBMA, it was also increased. Sorry about that. But in ALS, it can be in either direction. And in spinal cord injury, it's generally just the HDL. Fatty liver was seen in most of those neuromuscular disorders. Insulin resistance seems to be something that is common amongst the 4 different neuromuscular disorders. Though that being said, in ALS, for example, it is a protective mechanism. So if you have type 2 diabetes, it seems like it delays the onset of symptoms. And then last one was IGF-1, though, as I said, this was only found in mice in SMA, while there's a little bit more studies in the other disease. And again, there's some things that are truly unique to the different entities. But you know, so when we did compare this, we came across further question about whether we were even doing this right, and then the big thing that we needed to remember is that the studies in all those different fields, all those different neuromuscular disorders, they were not made to be compared. So often we would have a lot of findings in SMA, but it was not necessarily the same focus in the other diseases. And so it was really hard to actually corroborate our results. Sometimes the evidence is not clear-cut. It's mixed in other fields, and there's different opinions depending on the researchers. The age and spectrum of the disease is probably the most significant factor differentiating those diseases. So if you think of SMA, it's a wide phenotypic spectrum. Many present in childhood, with many individuals also seen in adulthood, while SBMA, ALS, and spinal cord injury is mostly an adult phenomenon, which brings about the other factors that we don't necessarily consider as much in SMA, such as if most of your population is above 50 years old, then you already have to think about phenomenon that already happens in the average population, which includes cardiovascular disease, type 2 diabetes, and other things that come with age, including increased cholesterol. And the extent of disease is also different. If you think about SMA, it's mostly the peripheral system, the peripheral nervous system. When you think about spinal cord injury, it's not all of your muscles that are denervated. It's only the muscle, the signal doesn't go to the muscle that is below the lesions that you had from the spinal cord. And then when you think of ALS, then you have a little bit more extent of disease that includes the CNS as well. So the last question was, well, there's many more, but the last question we'll cover today was mostly, so knowing that we don't necessarily have a lot of answers comparing that to other neuromuscular disorders, can we at least see if we can modulate this phenotype? And there's multiple ways we could modulate this. Well, we have all these different factors that were actually abnormal and misregulated. So we can touch all of these, but we thought one of the easy ones that we could do was actually just see if we change the diet of these mice, can we actually change their phenotype? So, and the reason we went that route is because the nutritional needs in SMA seems to be very, very different and very varied depending on institutions, depending on the needs of the patients, depending on the type. And as of yet, at least in my opinion, and from what I read and from what I know, it's really unclear as to what works best. And I think right now, we know that it's probably going to need to be highly individualized. There's no prospective studies as to what needs, what SMA patients need. More than 1/3 of families are modulating the feeding regimen without the medical care team, just telling you that, it's felt that the patients are also feeling that the feeding regimen that is provided to them is not appropriate or not adequate for them. And then from a nutritional intervention perspective, there was a recent study that showed that if you implement nutritional intervention prior to giving your nursing, you get better outcomes. So there is certainly a place that can be modulated and can probably help in the long run. And the interesting thing is that the early reports that we had discussed initially prior to having this huge hiatus in research, they were all advocating for diets that were only composed of carbohydrate and protein while limiting fat based on their findings that they had in their research. So we thought, that's interesting. Why don't we do this experiment and find out how the mice, what the mice do when they're put in different settings with different diet. So we took normal chow, which is essentially what we did all of the experiments that you previously saw. They were fed with normal chow. We took a low-fat diet, which only had 10% of fat. We took a high-fat diet, which had 60% of fat. And then we took a high sucrose, but low-fat diet. And what we found when we look at their survival was that you can see here, sadly, I didn't put the legend, but you'll have to trust me on this. So the green one is the high sucrose, low fat. The blue one is the low fat diet. And the red one is the high fat diet, and this is the normal chow. So what you can notice is that you can actually extend the lifespan of these mice by about 10 days just by changing their diet. And I have to mention that in preclinical studies, if you're not replacing SMN, this is actually results that are quite significant, because most compounds that are tried that do not increase SMN levels actually only leads to a few days difference in their lifespan. In this case, we almost doubled it. So that was quite significant. What we did identify is that this was not related to SMN levels. So the SMN levels didn't change at all. The weight of the mice didn't change at all either. And lastly, their livers looked exactly the same. They didn't have any change in how much lipids were in their liver, yet it seemed like it functioned at another level, whether it's at the level of all the cells using the right substrate. It's hard to know, and I think more research is needed at this time. And we always have additional concerns when we think about high-fat diet. It delays your gastric emptying. It may worsen your GERD and your reflux. And then lastly, there's always increased risk of what we know now may be a phenomenon in SMA, which is high total cholesterol. Though there's also concerns with high glucose. So it may worsen insulin resistance, it may worsen type 2 diabetes, and it may also lead to deficiencies in fat soluble. So we need the fat to use to actually absorb some vitamins. And so, it's not an easy trade-off to just say, oh, like this is the way, because the preclinical models showed that there's certainly a need for studies down the road that will address these points in controlled manner. So from a take-home messages, it seems like from our findings, SMA mouse models and SMA patients have higher susceptibility to having difficulties with fatty acids and fat, and that can present as fatty liver disease. We discussed about some barriers to translation, meaning that even though we find all these things in preclinical models, doesn't mean that all patients will have these things, because we know that genetics is different, their environment is different, and there's, you know, just the complexity also of the individual compared to mice is totally different. And sometimes there's also, you know, we have to think about how to carefully carry on with some of these experiments. So it seems like surely when you have low SMN that there might be a unique metabolic signature, meaning that it might not be the same as neuromuscular disorders that such as ALS, spinal and bulbar muscular atrophy, or spinal cord injury. Certainly there was some things that were the same, but also some things that were different. In preclinical models, it does seem like when you provide them with a low-fat diet, you can actually help in the long run. And certainly there's going to be more studies that are required to go forward and evaluate the true needs of SMA patients from a metabolic perspective. Finally, you know, we show through those studies that, you know, should there be a need for screening, that this can be easily performed and could be easily accessible. And so that's something that still needs to be studied and identified by clinicians seeing SMA patients. So thank you very much for listening, and Dr. Kathari and I will be happy to take any questions.
Thank you so much, Dr. Dickey, Dr. Kathari. That was excellent, really informative. It's really nice to see the questions that are coming in, and the comments have been really positive. Let's go through some of the questions. One is, are the effects on the liver, will they put individuals with SMA at higher risk of liver disease if they're also on pain medications, like taking Tylenol on a daily basis for several years?
So I think that's really hard to say, because we don't have really solid evidence that this, you know, this is necessarily the case for all SMA patients. I think this is something that would need to be discussed with their primary care provider. Let's say, if should there be evidence of any risk for the liver on imaging or something else. But hard to say from our studies. You know, we find this in preclinical models, but we really don't have a lot of data for SMA patients.
Yeah. Another question here is around at the time of diagnostic testing, is it part of standards of care right now to check for glucose intolerance or check for cholesterol? Is that part of standards of care?
No, it is not part of standard of care at the moment. Right now, this is fairly new studies. I think the last standard of the clinical guidelines for SMA were last done in 2020, and that was just after the study came out. So I don't know if it will be introduced down the line, but certainly at the moment, I don't think that this is standard of care and would be mostly individualized based on the clinician.
Great. I'll add that the only place where we're seeing that this is being done more is in clinical trials. So I know some of the gene therapy studies, the clinical trials, there are now publications coming out reporting on elevated liver damage, acute liver damage, partly due to the virus that's being used to deliver the good gene that's creating a toxic effect on the liver. But as a matter of fact, they're using that to assess baseline liver function prior to dosing, and then during the dosing, and then after the dosing. So they are starting to look at that. But it's certainly, as Mark Olivier said, it's not standard of care at the moment.
That's good. That actually ties into two questions that we received. It was around treatments that are currently available that you showed on one slide, Dr. Kathari, and it was whether there were any studies done to see if a certain treatment coupled with a certain a certain diet coupled with a certain treatment will lead to better outcomes. So this individual cited that Dr. Diggy mentioned one study with Spinraza with nusinersen, but they were wondering if there are other studies that have looked at diet times treatment.
So very, very new. The only study that came out that I seen was the one that I talked about, and that was published this year in 2021. So in the last 6 months. I do not believe that there is similar studies for other compounds. That being said, it doesn't necessarily mean that they won't come. I think it's just very, very new. So I think it just takes time sometimes to get around to doing the studies.
And maybe this question will help to address a few questions that are more around translating this information to people with SMA. But the question is, how long does it take from a preclinical model to be translated? So how long does it take to translate information from a mouse model to human is a question. Now that could be more broadly or on average. What are your thoughts on that?
Well, maybe I'll tackle that one, Marco, and then you can try to address it. That's the reason I put that slide on about the first mouse model was over 20 years ago, 21 years ago this year. Just to kind of point out that, although progress is amazing and we can really discover things at a rapid pace, just look at the COVID vaccine and how quickly it came on into our clinics. But remember, even for that vaccine, it's 30 years of research on the lipid delivery methods that led to its success overnight. And similarly, in the SMA field, the first mouse model was there 20 years ago, and yet the first therapy that went into the clinic was about 5 years ago, 4 to 5 years ago. So it does take time. Now, having said that, I think the uptake and the appreciation of the results from the preclinical system is much more rapid. The research now seems to demand that we also look at the clinical translational value and include whatever analysis we can from clinical studies, so that the translatability of the basic research is going to be a lot more enhanced. So having said all that, how soon will some of these findings have an impact in the clinic? I think it's not something we can predict, but I think what I'm seeing is an appreciation from the clinicians that there's likely to be peripheral organ issues in spinal muscular atrophy, which is a huge step from even 5 to 10 years ago when you talk to clinicians. They didn't want to listen to you because they were focused on the motor neuron component, and that was it. So I think we've come a long way in 10 years. Now, with the acknowledgement that there could be other things going on, I think we'll see a much more rapid sort of translatability of some of these other more recent findings. Marco, what do you think?
Yeah, no, and I should add that, some of the things that we do in mice sometimes might also never be translated just because of the sheer way that experiments are made, right? There's just things that cannot be translated in the clinic and some things that are much more experimental. So knowing that, there's certainly some aspect that can't be translated at all. The aspect that we know that can be translated always depends on multiple factors. First, visibility, and down the road is also making sure that everything's safe for the patients, and then finding there's multiple layers to that, adding to funding, resources, and clinicians that have patients that are interested in participating. Generally, I would say it's not the participation that is the difficulty. I think it's mostly the multi-steps that you need to have rigorous research that is safe for patients.
The That's excellent. That's a great point to end today's webinar on. Thank you again, Dr. Diggy, Dr. Gathari, for a really insightful, informative webinar. It's a really nice way to learn more about your recent manuscript that was published and the latest research updates in this area. So thank you both so much. Thank you to Biogen and Roche for supporting the Let's Talk NMD webinar series. And we hope to see you at our next webinar on SMA adult outcome measures. Thank you both. Have a great afternoon.
Bye.
Bye-bye.